So moving on to this talk. So we're going to talk about focal liver lesions, and I'll start off with a relatively straightforward case to go through some basic principles. Here are T1 weighted gradient echo and T2 fat suppressed images through the liver in a patient who has an obvious mass in the left lobe. The lesion is hyperintense on the T2 weighted acquisition, which is not a very specific finding, and so we tend to rely on contrast enhancement to characterize the lesion. In this case, we have a very classic appearance, marked enhancement in the arterial phase and the peripheral portion of the lesion in a nodular pattern, a broken ring pattern, and then over time, this lesion fully enhances. And I think all of us in the room would feel very comfortable with the diagnosis here of a hemangioma. Hemangiomas are the most common lesions that we see. They affect about 5% of the population, classically bright on T2 weighted acquisitions. They have three typical patterns of contrast enhancement, the one that I showed you. When the lesions are smaller, they can be flash filling. When they're larger, they may not fully enhance over time. They may not completely fill in. So here are a couple of other examples just to show you the spectrum. Giant cavernous hemangioma, again, very, very bright on the T2 weighted acquisition. Over time, with contrast, there is progressive filling in, but even on the delayed acquisition, there is incomplete enhancement of these very large hemangiomas. Here's another example on the opposite end of the spectrum, a much smaller lesion, again, bright on T2 weighted acquisitions. In this case, in the arterial phase, it is uniformly enhancing. This is a flash filling hemangioma. And the way to distinguish this from other arterial enhancing lesions is the fact that it persists, it holds on to the contrast through the equilibrium phase. One question that often comes up is whether we can rely solely on the T2 weighted images to diagnose a hemangioma, because the T2 times for these tumors tends to be very long. And the answer to that question is no. We really do need to give gadolinium because there are other lesions, such as hypervascular metastases, that can also have a very long T2 relaxation time. So bright on T2 is really insufficient for characterization, and we rely on our contrast-enhanced acquisitions to characterize these. One of the advantages of new high-resolution contrast-enhanced acquisitions, the 3D acquisitions, is that we can characterize even very small tumors. So in this case, on these two T2 weighted acquisitions, you can see a very small sub-centimeter hyperintense lesion in the dome of the liver. On the arterial phase, we use a 3D acquisition, which is referred to as VIBE on Siemens, Thrive on Philips, and LAVA on the GE systems. This is a 3D acquisition for contrast-enhanced acquisitions. And you can see on the arterial phase, there's not much enhancement, but on the subsequent phase, especially on the coronal reconstruction of these axial images, you can appreciate that there is a nodular component to this, so even very small sub-centimeter hemangiomas can be characterized if you use very high-resolution acquisition techniques. Here's a companion case just to contrast the pattern of enhancement. In this case, this lesion has a peripheral rim of enhancement, but is a continuous rim. This is a much nastier looking lesion. And contrast that to the hemangioma, we can make the diagnosis here of a metastasis. One more companion case, another patient here, another lesion that's bright on T2 weighted acquisitions. Following contrast, it has a kind of unusual appearance, quite a lot of enhancement around the rim of the tumor involving the liver parenchyma, but over time, the lesion does progressively enhance. This would be an atypical pattern for hemangioma, and I think the diagnosis becomes more apparent when you have clinical history. And in this case, when we followed up after antibiotic therapy, this lesion became or regressed significantly, just reminding you to think about an abscess in the differential diagnosis. Let's go back to this case and take one more look at it. Again, on the T1 and T2 weighted acquisitions, we predominantly see just this one lesion, but on the contrast-enhanced images, I wonder if you can see an additional lesion in this case. If you look at the arterial phase, you can see in the right lobe that there is a hypervascular lesion here. It's really pretty much only seen on the arterial phase, maybe a little hypointense here, not really apparent on the T2 weighted acquisition. In a patient without a history of cirrhosis or hepatitis, this is most likely a hepatocellular tumor of benign etiology and most likely an FNH. So let's talk a little bit about FNHs. These are most commonly found in young women. They are hepatocellular tumors. They may have a central scar. Because they're hepatocellular, they tend to be pretty close to isointense with the rest of the liver on T1 and T2 weighted images. They do have arterial blood supply. They're hyperintense on the arterial phase and may be nearly isointense to the liver on the other phases, except for the central scar when that's present. Incidentally, there is an association that's been reported by Vilgrand and colleagues between FNH and hemangiomas, as we see in this case. They don't have to be in the same lobe of the liver, but there is an association. About 20% of FNHs have hemangiomas in the liver somewhere else. Here's just a companion case. This is a little bit of an eye test, but if we look in the medial aspect of the right lobe, there's a lesion here. It's a little bit hyperintense on the T2 weighted acquisition, markedly enhancing on the arterial phase, except for a central region which enhances here on the delayed phase, the central scar, which is seen in under half of these cases, but when seen is pretty characteristic. Now let's move on to the next case. Here's a different patient now with the right lobe of the liver, and now we're looking at T1 weighted gradient echo images at 2 echo times, an in phase at an echo time of 4.4 milliseconds, and an out of phase at an echo time of 2.2 milliseconds. This is at 1.5 Tesla. And we can see that on the in phase, it's very difficult to see, but there is a subtle lesion here that is much more apparent on the out of phase acquisition. And so I'd like to just review the significance of in and out of phase imaging here for characterizing lesions, especially those that lose signal on the out of phase. So just by way of review, water and fat protons tend to precess at slightly different frequencies. They start off together, but they precess at different frequencies so that at an echo time of 2.2 milliseconds, they point in opposite directions. They're out of phase. And that means any voxel that contains a relatively equal amount of fat and water will lose signal because the fat and water will cancel out. By 4.4 milliseconds, the fat and water are in phase again, so the signal is additive, and then it's out of phase again at 6.6 milliseconds. So any voxel that has an equal amount of fat and water will lose signal on the opposed phase acquisitions, and that's why we see this India ink artifact around tissues that are surrounded by fat, and also indicates that there is fat in this liver lesion. Here on the contrast-enhanced images, slightly hyperintense on the arterial phase, a little bit hypointense on the portal venous phase. Again, in a patient without any underlying cirrhosis or liver disease, a fat-containing liver tumor is most likely hepatic adenoma. These, again, are most commonly found in young women. They have the association with contraceptives or steroids. Again, these are hepatocellular tumors, so on the T1 weighted images and T2 weighted images, they are classically nearly isointense to normal liver, except in the setting of fat or hemorrhage. On the arterial phase, they tend to be hypervascular, but not quite as intense as the FNHs that we've seen already. In order to differentiate these from other hepatocellular tumors, hemorrhage and fat can be very helpful. Here, just a side-by-side comparing FNHs with adenomas to note the differentiating features. They both are benign hepatocellular tumors. They can affect young women and be multiple. Statistically, you're most likely to encounter an FNH 6 times as common as an adenoma. And if you see the central scar, that can also be helpful for an FNH, whereas for adenomas, the fat, hemorrhage, necrosis, pseudocapsule can tip you in that direction. Let's also briefly talk about fatty liver lesions. Of course, you can see focal fat in the liver. Hepatic adenomas can contain fat. Occasionally, you can see hepatocellular carcinoma with fat, although in the setting of cirrhosis, typically. And then rarely you can see primary lipomatous tumors of the liver. So we'll just look at a couple of examples just to round out this discussion. Here's a in phase and a post phase, and again we see signal loss in this region, a typical location for focal fat, again the classic locations adjacent to the ligamentum teres, central tip of segment 4 along the gallbladder fossa. This would be a typical location, and again there's no capillary blush in order to distinguish it from an adenoma. This is one of the relatively uncommon fat-containing hepatocellular carcinomas that we've seen. Here's the in phase and the out of phase. You see a lot of signal loss here. And the giveaway that this is a malignancy is, first of all, you have cirrhosis, splenomegaly with gamma antibodies, and then on the arterial phase, you have arterial enhancement in this portion of the tumor, which is, again, very suspicious for hepatocellular carcinoma. These are pretty uncommon, and just because it's bright on the T1 doesn't necessarily mean that it's fat, so the in-phase and out-of-phase acquisitions can help you characterize the fat in the lesion, and the worrisome components are those that enhance on the arterial phase. Okay, on that theme, we'll move to the third case in this lecture. Here's a middle-aged man with chronic hepatitis. T2-weighted acquisitions show a slightly hyperintense lesion in the dome of the liver. It's hypervascular on the arterial phase, and on the portal venous phase, it becomes slightly hypovascular with a rim of persistent enhancement. In the setting of hepatitis and the cirrhotic, this is a hepatocellular carcinoma until proven otherwise. Classically, these are hyperintense on T2 and show arterial enhancement. The later phases of contrast can also be helpful if you look for the washout with ring enhancement. But I want to talk a little bit more about the appearance of hepatocellular carcinoma in the setting of cirrhotics, and particularly I want to address these two questions that frequently come up. First of all, what's the significance of T1 and T2 weighted signal intensity characteristics of these nodules? And secondly, what's the significance of gadolinium enhancement? So to answer the first question, I turned to a paper that was published by Glenn Krinsky, a former colleague of ours at NYU, and he did a very nice study comparing the imaging findings with MR with whole liver explant pathology. So he did slice-by-slice comparisons with thin section pathology compared to MRI. And in these path-proven hepatocellular carcinoma cases, I highlight here in yellow the signal intensity pattern on the T1 and the T2 weighted sequences without contrast. And I just want to point out to you how variable these are. Here's a lesion that's dark on T1, bright on T2. Bright on T1, ISO on T2. Bright on both. Bright on T1, not seen on T2, presumably ISO, not seen on T1, dark on T2. So you have the whole spectrum of signal intensity characteristics on these path-proven hepatomas. And let me just show you a couple of the images from his paper. So here's a whole liver explant slice. Here are a couple of tumors in the cirrhotic liver. On the ex vivo T1 weighted acquisition, these are bright on T1, dark on T2. We wouldn't typically think of these as hepatomas, but both of these are path-proven hepatomas. And take a look at this example. In this particular explant, there are 3 lesions. Bright on T1, 2 of them, dark, the middle one. And then on the T2 acquisition, dark and bright. So we have the range of signal intensities, and all 3 of these turned out to be hepatomas. And in fact, at pathology, the differentiating features are the amount of trabeculi versus the pseudoglands. So the pseudoglands tend to behave more like water, so they're bright on T2, but the tumors that have more of the thickened trabeculi are dark on T2, but these are all hepatomas. So to answer this question, what's the significance of T1 and T2 signal intensity characteristics? Very little. I wouldn't put much weight on this at all. On the other hand, let's talk about gadolinium enhancement. Now, to understand the pattern of gadolinium enhancement of these tumors, it's very helpful to think about the natural history of these. Most of these tumors start off as regenerative nodules, low-grade and high-grade dysplastic nodules form within them, and then they evolve to hepatocellular carcinoma. And with this evolution, the blood supply evolves from being predominantly portal venous in origin to hepatic arterial. Here's just a schematic showing you the evolution from a dysplastic nodule with a microscopic focus of hepatoma, the so-called nodule within a nodule pattern. And then that hepatoma grows and gradually dominates the lesion, and as that grows, there's progressively more arterial blood supply. These arteries are actually newly developed arteries. They are different from normal appearing hepatic arteries in that they're not associated with portal vein branches, and they are associated with increased vascular endothelial growth factor as well. So this neoarteriogenesis in the hepatomas explains the hypervascularity that we see on the arterial phase for these cases. And that's what differentiates the hepatomas from regenerative nodules and from most dysplastic nodules. And in fact, if you look at the CT and the MR explant literature, About 10%, 7 to 11% of hepatomas are visible only on the arterial phase, and that is really because of this hypervascularity or the neoangiogenesis. So if we look back again at Glenn Krinsky's paper, looking at the arterial phase of enhancement for these same series of tumors, almost all of them are hypervascular on the arterial phase. Sometimes it can be a little bit difficult to judge whether something is enhancing on the arterial phase, so here's one of those slightly tricky cases. As I mentioned, they can have all sorts of signal intensity characteristics, so if the lesion is bright on the T1 weighted acquisition without contrast, here it's dark on T2, but if it's bright on the T1 pre, it's difficult to say whether or not there's enhancement if it's still bright on the arterial phase. And so in these cases, we recommend doing a subtraction, subtracting the unenhanced from the enhanced acquisition. And on the subtraction, you can see very clearly this tumor is definitely enhancing. Any arterially enhancing tumor in the setting of cirrhosis has to be worrisome for a hepatoma. So to answer the second question, this is where the money lies. The significance of gadolinium enhancement is huge, particularly on the arterial phase. How good are we overall at diagnosing hepatomas in these patients, both with MR as well as CT? The results are actually surprisingly poor, particularly if you focus on the data that uses whole liver explants, which is really the data set that you want to be paying attention to. In these studies, some of which I've cited here, the overall sensitivity for MR on a lesion-by-lesion basis is only about 50 to 60%, and it's really size dependent. So if the lesions are over 2 centimeters, we're pretty good, 80 to 100% depending on the study that you look at. If the lesions are 1 to 2 centimeters, we only detect about half of these. And if they're less than 1 centimeter or in the setting of carcinomatosis, we're really pretty bad. The similar results actually have been found slightly lower, but very similar with CT on a lesion-by-lesion basis. Well, what can we think about doing in order to improve the sensitivity? One of the interesting studies that has come out recently from a Japanese group has been to look at multiple arterial phases with the thought that some of these hepatomas enhance a little bit earlier in the arterial phase and some enhance a little bit later in the arterial phase. So they compared a double arterial phase acquisition with a single arterial phase acquisition and found that they could improve the sensitivity for hepatoma, particularly for the smaller lesions, those less than or equal to 1 centimeter. They could see almost 80% of those if they used a double arterial phase, and only about a third of them with a single arterial phase. And this has led us to be quite interested in the concept of perfusion imaging with multiple arterial phases. Dr. Tauli, who you'll be hearing from next, is performing some research using these very fast 3D acquisitions. You can acquire these in less than 5 seconds and get the whole liver. And by repeating these over time, you can get multiple arterial phases, and he's examining whether this can improve our detection of hepatomas, particularly the smaller lesions. Before I leave this topic, I just want to review some of the other kinds of nodules that you see in these cirrhotics, because it can be very confusing, I think. The regenerative nodules tend to be very similar to normal liver parenchyma. They are normal liver. And the arterial phase should be isointense to the liver. They can cause a lot of distortion, as in this case. You can see these areas of regeneration can really distort the liver parenchyma, but it's important to realize that the arterial phase should match the rest of the liver parenchyma in order to distinguish these from tumor. Here's another example of more focal, more well-defined regenerative nodules. They can have signal intensity pattern that typically is iso or hyperintense on T1, typically hypointense on T2, and the key here for distinguishing them from malignancy is that they are not hyperintense on the arterial phase. Sometimes these nodules can be siderotic, that is iron containing. When you see the iron, they tend to bloom on the gradient echo sequences with a longer echo time. So you can see the more subtle iron nodules here look more prominent at the longer echo time, both in the liver as well as in the spleen. There was some controversy in the literature about whether these increase the risk of developing hepatoma, and the answer is probably not. They're just associated with the regenerative process. What about dysplastic nodules? Again, these are the pre-malignant lesions. These can be very difficult to differentiate from regenerative nodules. They have the same kind of signal intensity pattern, and at pathology, they're really pretty common, but for MR, they're really very difficult for us to diagnose. Here's our take-home message for those of you who've been fading out. You can come back in for this slide. Nodules in cirrhosis. Any dominant nodule greater than 3 centimeters should be considered suspicious, regardless of its signal intensity characteristics. Any nodule that shows arterial phase enhancement should be considered suspicious, especially those that are bright on T2. And just remember that overall, we're really not very good at diagnosing smaller lesions. So careful monitoring of these patients with Q3 or Q6 month imaging is certainly justified. This is what we're trying to avoid by doing frequent monitoring. Here's a patient with cirrhosis, a large lesion in the right lobe of the liver. Here's the coronal reformatting showing you the metastasis to the chest wall. Well, on the theme of hepatomas, I want to go over this case with you. This is a case that illustrates a problem that we have now that we are doing such high spatial resolution imaging. Here's a patient, cirrhotic patient. This is the arterial phase 3D acquisition. And we see multiple little dots, which I've highlighted a couple over here, that are bright only on the arterial phase. We don't see them on T1 or T2 weighted imaging, and they don't seem apparent on the portal venous or equilibrium phases. So what do we do with these little hypervascular lesions? Well, most likely, many of these turn out to be arterial portal shunts. These are findings that we see on imaging that seem to have no pathologic correlation. They appear as transient areas of hypervascularity, and they have no associated T1 or T2 abnormalities. What we're trying to avoid missing is lesions like this. So here's a lesion, again, little dot seen on the arterial phase, patient with hepatitis. This patient had a leather dominant nodule a little lower in the liver, but I'm just focusing on this dot for now. And 6 months later, the lesion grew. On the portal venous phase, though, I just want to point out that this lesion actually has an interesting appearance on the in the sense that it is hypovascular in the center and with a rim of enhancement around it. So at this phase, we would actually be more worried about this being something real, but at this phase, it was very difficult for us to diagnose this tumor. So the question is, how do we distinguish these arterial portal shunts from that hepatoma that we just showed you? Well, Agnes Holland, a former resident in our department, did a very nice study looking at whole liver explants, trying to evaluate the significance of these little arterial phase enhancing lesions. And in a study of about 40-some patients with whole liver explants, she found some interesting findings. First of all, if you see these little dots only on the arterial phase, less than 2 centimeters, they're most likely AP shunts. The vast majority of them, 93%, turned out to be AP shunts. The only ones that were associated with tumor that turned out to be hepatomas were those that were associated with a dominant nodule elsewhere in the same liver. So if you see a few of these dots and there's no dominant hepatoma, in our series, 100% of them turned out to be AP shunts. Only in the setting of a dominant cancer elsewhere in the liver did some of them turn out to be little hepatomas. So putting this together, talking about these arterially enhancing lesions, we have the differential of AP shunts, small hepatomas or dysplastic nodules, and flash-filling hemangiomas. So these hemangiomas are the easiest to dispense with because we see the persistent enhancement on the portal venous phase. Distinguishing between the AP shunts and the small hepatomas really depends on whether there's a dominant hepatoma. If there's no dominant hepatoma, in our series, all of them turned out to be benign. If we look at the portal venous phase, and there's a little thin rim of enhancement or any hypovascularity, if we can see anything at all there, then we start to worry about a hepatoma. And regardless, when we're worried about this differentiation, close follow-up is really warranted. Okay, I want to finish with a couple more cases just to illustrate a couple of teaching points. Here's another patient who has a lesion again in the right lobe of the liver. And on this arterial phase, there is this wedge-shaped area of abnormal hyperenhancement on the arterial phase. And I want to discuss this perfusion abnormality in this case. This lesion has a rim of enhancement. It's very similar to one that I showed you earlier. This does not look like a benign lesion. It looks like a malignancy. And in this case, I think this is a metastasis. Here are some other images, the T1 and T2 weighted acquisition. You can also see some other lesions in this patient's liver. And the question is, what is causing this perfusion abnormality? And if you see this on a CT, it might be more familiar to you, but we also see the same kind of finding on an MR. This is referred to as a THID on CT or a THAD on MR, that perfusion abnormality. It's a transient hepatic intensity difference, and it's due to the small portal venules distal to a mass being occluded, and that gives rise to preferential arterial blood supply. It can be a very early sign of small tumors before the tumors are even visible. And in fact, it was first described in the setting of breast cancer metastases before the breast cancer tumors could be seen. But nowadays, it's realized that the most common source of these THIDs or THADs are benign lesions such as hemangiomas. In this case, this was a THID secondary to a colon metastasis. And then I'll finish with one last case. This is kind of an Aunt Minnie that we see every couple of months. Here are T2 weighted acquisitions, a coronal and an axial, and we see in this patient who I think was referred for an MRCP, we see multiple hyperintense lesions throughout the liver. I don't show you the contrast enhanced images, but these are non-enhancing. And this is a classic appearance of biliary hamartomas. This is really an Aunt Minnie. These are benign liver malformations. They represent disorderly collections of bile ducts. They can be single, multiple, or diffuse, but in the diffuse form, they're pretty classic. I suppose you could be worried about, say, metastatic mucinous tumors or polycystic liver disease, which is sort of part of the spectrum of this. But in this case, when there's no history, no clinical history, and there's no abnormal enhancement at all, these are really very typical appearance for biliary hamartomas, also known as von Meinberg complexes.